Hey everyone, and welcome. So glad you're here. If you're getting ready for your fundamentals lecture on oxygenation and circulation, you've come to the perfect spot. We're about to run through all the core vocabulary you need so you can walk into that class feeling confident and ready to go. Okay, so here's our game plan for today. Think of it like this. We're going to follow the entire journey of a single breath, from the second it enters the body to how our cells actually use it, and finally, what we as nurses can do when that process breaks down. First things first, we have to start at the very beginning, with the most basic action there is, just the simple physical act of getting air into the lungs.
So this is the first term you absolutely have to lock in, ventilation. The key word here is mechanical. We're not talking about oxygen or gases just yet. This is purely about the physics of moving air in and out. Think of it like a pump. And this distinction is huge in a clinical setting. Why? Well, because if a patient can't do this first simple step, if they can't physically move air, then none of the other steps even matter.
Now, what's really cool is that this one action, breathing, is actually two very different phases. Inspiration, that's breathing in, is an active process. Your muscles, like your diaphragm, have to work. They have to contract to pull that air in. But expiration, breathing out, is usually passive. Your muscles just relax, and the air flows out on its own. It's a super efficient system, and knowing this helps you spot when a patient is working way too hard just to get air out.
All right, so the air has arrived in the lungs. Now what? This is where the real magic starts to happen. Let's look at how that simple act of ventilation kicks off the process where the air we breathe actually becomes useful to our body.
And that magic is powered by this one simple concept: diffusion. It's just physics, really. You've just inhaled, so your lungs are packed with a high concentration of oxygen. The blood coming back from your body, well, it's used up its oxygen, so it has a low concentration. So what happens? The oxygen naturally moves from the lungs into the blood, from high to low. No energy needed. It's beautiful.
And check this out. Diffusion is a two-way street that's happening in two different places. In the lungs, you could call it pickup time. We're loading up the blood with oxygen and dropping off the carbon dioxide waste. But then, out in the tissues, it's delivery time. The blood drops off that precious oxygen to the cells that need it and picks up their CO2 waste to take back to the lungs.
So we've picked up the oxygen, but how do we get it from the lungs to, say, your big toe? For that, you need a delivery service, a kind of biological superhighway. And that, of course, is a circulatory system. And this brings us to our next key term, perfusion. Perfusion is basically the word we use for a successful delivery. If ventilation is getting air in and diffusion is getting oxygen into the blood, perfusion is the proof that the blood is actually reaching the tissues. In the hospital, this is what we're always trying to assess. Is the patient perfusing well? So how do we measure how good that delivery service is? How well is the heart, our pump, actually working? Well, we use this simple but incredibly powerful formula. Cardiac output is the total amount of blood your heart pumps in a minute, and it's figured out by multiplying how much blood gets pumped with each beat, that's your stroke volume, by how many times it beats per minute, your heart rate.
Let's dig into that stroke volume a little bit more because it's important. You have preload and afterload. Think of preload as how much the heart muscle is stretched right before it squeezes, basically how full is the tank. And afterload is the resistance, the squeeze. It's how hard the heart has to push to get that blood out into the body. Both of these are going to directly affect how much blood gets pumped with every single beat.
You know, a lot of people think the circulatory system is just one big loop, but it's actually two separate ones working together. You've got the pulmonary circuit, that's the short trip from the heart to the lungs and back again. Its only job is to pick up oxygen. Then you've got the much bigger systemic circuit, which takes all that freshly oxygenated blood and delivers it to every other part of your body. Okay, this whole system is, well, it's pretty complex, right? So who's running the show? Let's take a little peek inside the body's automatic control room that manages all of this without us ever having to think about it. Your body has this incredible dual control system. First, you've got neural regulation. Think of your brainstem as the main command center that sets your basic breathing rhythm, your autopilot. But then you've got chemical regulation. You have these little sensors all over your body that are constantly checking the blood's CO2 and oxygen levels. If your CO2 starts to creep up, those sensors send a message to the brainstem that says, hey, speed things up a bit. And this right here is a clinical cause and effect chain you will see again and again with your patients. It's a domino effect. It often starts with hypoventilation, The patient isn't moving enough air. That directly leads to hypoxia. Not enough oxygen is getting to the tissues. And if that gets bad enough, you can actually see the physical sign of cyanosis, that bluish color on the skin and lips. And that is a major red flag.
So finally, let's tie all of this theory to what we actually do as nurses. When these systems start to fail, what's in our toolkit? Let's look at some of the ways we can help our patients breathe.
These are some of your most common first-line tools. A nasal cannula? That gives the patient a little boost of extra oxygen. A nebulizer turns liquid medicine into a fine mist they can breathe right in. And humidification is super important, because the medical-grade oxygen we use is really dry, and this just adds some moisture back in to keep their airways from getting irritated.
Now, sometimes the problem isn't a lack of oxygen, it's that there's a roadblock in the way. That's where these come in. Chest physiotherapy, or CPT, uses things like vibration and percussion on the chest to help break up and move mucus out of the lungs. And in more serious situations, a tracheostomy creates a direct surgical airway into the windpipe, completely bypassing any blockages higher up.
It's also really important to know the difference between your common bedside tools. An incentive spirometer is a therapeutic device. You're going to be teaching your post-op patients how to use this to take deep breaths and keep their lungs healthy. A bronchoscopy, on the other hand, is diagnostic. That's a procedure where a doctor uses a camera to actually look inside the airways.
So there you have it. You've got the core vocabulary, from ventilation all the way to perfusion. You know all the different parts of the puzzle now. The next step, and this is really the start of thinking like a nurse, is to ask yourself, what happens when one of those parts fails? That question is exactly what your lecture is going to be all about. You've got this.